Hi, I'm Katie Crane, and this is the Pilates Lounge. Hi, everyone. Welcome to another episode of the Pilates Lounge Podcast. My name's Katie Crane, and we are still on our role of exploring the topic of fibromyalgia. Today, we've got on the episode Rob Nash from Heal and Thrive in around Melbourne, Victoria, in Australia. So thank you for coming onto the show, Rob. And I'm literally going to hand it over to you. So why don't you tell us a little bit about yourself and the work that you do?
Thank you. Yeah, it's really nice to be here. So I call myself an integrative exercise physiologist because I am an exercise physiologist, but I feel that doesn't quite capture everything. So I added integrative, and I'm being flexible with that word as well. And for the past 12-ish years, it might be 13 now, I'm not sure, but it's up and around there. I've been predominantly and more so as time goes on, focusing on working with what I call chronic invisible illnesses, bit of an umbrella term there. Predominantly chronic fatigue syndrome or myalgic encephalomyelitis, for those who want the big word, fibromyalgia, chronic pain, and a few other conditions that also fit into that umbrella, like POTS, or postural orthostatic tachycardia syndrome, and that's a whole other umbrella as well. Long COVID, and chronic pain in general, and dysautonomia. So the whole bag of those sorts of things. I've been doing that for quite a while, and as I said, more and more. And I'm just, it's just an area that I've always been drawn back to, and just haven't really left that space, which has been nice. And I don't really focus on much of the biomedical side. It's more about educating, coaching, and providing really holistic care for those sorts of clients. Yeah.
Why? Well, how come you chose that? Like, what do you think drew you to these complexities to start with?
Yeah. I get that question a lot, and sometimes it's a very loaded question. Like, some people are just going, why would you do that? Because these conditions and the people with these conditions, they're extremely complex and very misunderstood, medically misunderstood. And I remember it was touched on in my studies in exercise physiology with about one slide, I think, and it was just embedded into a unit somewhere. So that was all of the education that we got on, and I think it was just one slide covering all of those conditions. This is them, so not much detail. I got it. So I'm also a myotherapist by background, and that's sort of where I began my allied health study journey, or really massage and then myotherapy. And I, just by chance, one of the lecturers in my myotherapy course, or a couple of them maybe, they had just finished doing the Explain Pain courses by Laura Mosley and David Butler, and this was, we're talking about 2012 or 2013. So it was pretty fresh. It was a really, really new, exciting concept. And they just happened to be doing some sort of extracurricular. They just sort of said, anyone who's interested in a bit of chronic pain, we'll do some workshops on it. So I put my hand up and started learning about chronic pain, and it fascinated me. It resonated so strongly with what, thinking about the biopsychosocial model, where all I've been taught is that pain comes from the muscles, pain comes from broken stuff in our body. And, if we fix that broken stuff, or if we massage or dry needle or whatever, then that's just going to fix it. And, we're not going to be able to fix everyone, but that should get most people. And that wasn't my experience as a therapist. And yeah, so this chronic pain stuff really something just lit up in my brain. And
Mm.
that's the start of it. And I suppose over the time I've also had a few issues here and there with chronic pain, or I should say ongoing pain in parts of my body, various parts. Um, and I just had a knack for it, a real interest in it, a fascination in it. And yeah, then I suppose I'll speed up the story a little bit. End up working for a clinic that specializes in chronic fatigue syndrome. The similarities between that and fibromyalgia were just, clear as day. Almost two sides of the coin, almost, with those two conditions.
Mm.
Not quite exact, but yeah, pretty close. And yeah, I just started really specializing in that area. So it's been a long, fun journey. Yeah.
Yeah, sure. So, are you happy to touch on, like, I know that, we're rolling off this whole series on fibromyalgia, but we are actually then rolling into a series on chronic pain. So maybe
Yeah.
this would be the perfect opportunity for you to explain, like, those two sides of a coin. Like, what are the similarities, and then what are some differences that you see?
I mean, fibromyalgia is a type of chronic pain. Um, and there, yeah, I suppose I'm just trying to have a think. There's a lot of similarities. I suppose the the main distinction with fibromyalgia, um, we'll just back up a sec. Fibromyalgia, and then we'll just talk about maybe chronic pain in more of like a an area, like a focal area of the body. That's maybe a nice, sensible way to put it. Fibromyalgia
Perfect.
typically is a whole body experience of pain or discomfort, and it comes and goes, and it seems to have a mind of its own. Um, can be very. I think people with fibromyalgia intuitively know that they haven't injured themselves. Like this isn't like low back pain where they may have moved funny or slept funny or bent over, or there's a mechanism of injury there. Most people with fibromyalgia, that really hasn't occurred. So yeah, they're not super concerned about like an old injury that's occurred to them. There's different reasons, which I'm sure we'll get into. Chronic pain, I suppose we're talking a bit more about a specific region of the body. Think about like chronic low back pain or rotator cuff injuries, chronic neck pain, really any region of the body. Um, and typically that's a bit more associated with either an injury or um, degeneration of a part of the body, like bulging discs and slip discs and arthritis. Uh, yeah, that's the main difference, I'd say. Hmm.
And then, because when you like, were working with this guy and he'd done the explain pain
Yeah.
um course, which I did it a long, long time ago as well.
Mm.
And the whole part of what they talk about when it comes to chronic pain is it's not like you don't have that injury anymore. Like it's like there's nothing that's confirming that the disc bulge that you had 12 months ago is still the issue that you've got now, yet are still experiencing this the pain symptoms from it, right?
Yeah.
Because physiologically, the body should have healed by now.
Yeah.
Um,
Yeah. Correct.
so is there a similarity there? Like, where, you're still living with this
Mm.
pain, this issue, but is it still the issue that's bothering you?
Yeah. And look, I think when all of this, when explained pain really gained traction, um, it was really revolutionary. And I think the pendulum swung really, really hard towards this. Pain is a very well, I mean, technically biopsychosocial. We were kind of, using that model, but I think the community grabbed onto the psychosocial part and almost forgot about the bio part. So we almost forgot completely about the body. probably because it was exciting. It was very exciting to me. So just to sort of add some more elements that you can play with. So I think that's what happened. And in doing so, yeah, we just went, oh, look, any injury that you've had or anything that's been going on with your body that's more than 6 months old is now completely irrelevant. And I'm guilty of saying that to people, because yes, the story that we are now told and educated with is that injuries happen, and yes, we can get acute pain, but that acute pain and that injury should heal up, like give it conservatively like 6 months, and that should not be the driver of pain. I don't think it's that clear cut anymore. Well, no, I don't think it ever was, but we thought it was. So I think the pendulum is now balancing out. I think it's in a good space where we can actually go, yes, absolutely. Our headspace, what's going on psychologically, stress-wise, what's happening in our lives, our memories, our understanding of pain and injuries, really important stuff. Highly, highly well, sorry, I'm not sure what I was saying. They're big factors, basically, those things. But we can't dismiss what's going on in the body as well. Those old injuries, they may still be present. Not all disc bulges do heal. A lot of them do. That's good news. But yeah, a lot of injuries, like if you think about complete tendon ruptures and rotator cuff injuries and arthritis, they're still there. And they're going to be driving some nociceptive input to the brain, but we just know that that's not the end of the story there. We know that there's probably going to be sensitization going on, and I can explain a bit about what that is as well. If you think, yeah, your audience better than I do, I suppose. Yeah.
Mm.
Mm.
Yeah. Do you want to go through the nociceptors and
Yeah.
the way that the body, like the whole mechanism of pain, maybe, because
Yeah.
do you find that is relevant to fibro as well?
Um, that's a great question. I would say it is. Look, there's, again, in this sort of pendulum swinging back towards a bit more of a central area where we're thinking a bit more holistically again, including the body. There's been some recent papers that have confirmed that, yeah, we actually do need nociception for pain to occur. Okay, that's a lot of very convincing papers, very recent papers are saying this. We were in a place where, and I'm pretty sure, Lorimer Moseley and Butler were saying that all you need is a brain, all you need is a nervous system, central nervous system, and you can experience pain without any nociception at all. Just to explain nociception, think about nociceptors as pain receptors, although that's not technically correct. Nociceptors, these are nerve endings, free nerve endings right throughout our body. And these are the things that detect danger. I suppose the best thing to call them is more danger receptors. They don't actually produce pain. They send danger relevant messages to the brain. Okay. And yeah, so these papers were saying, well, actually, the brain does need to be receiving some sort of information about nociception for pain to actually occur. That seems to be the consensus these days. But I suppose it's more about the amount of pain, the severity of pain, the type of pain, and that's where the brain and the central nervous system, that's where all of that processing is done. So, yep, might be receiving some information, but then the brain decides, how big is this? How much of a threat is this? What's the context of it? That's where it gets really, really interesting, I think. So, yeah.
Mm, mm. And those signals of danger, um, which then are experienced as pain, right?
Yeah.
And then potentially that the messaging somewhere along the line gets scrambled or gets hyper
Mm.
like it's more than what it actually is, or
Yeah.
and then is there a potential that that experience is from the stories that I've been listening to from other people that I've interviewed now, who are either living with fibromyalgia or who have lived with fibromyalgia, you know, it it seems to me so far, and it's not like I've interviewed a million people, it's only 5 people, but there's still a very similar story of extreme traumatic events leading to this experience
Mm,
and or long-term long-term relatively high grade stress that leads to this whole fibromyalgia taking over. So so is it then fair to say that a whole scrambled experience is that they're holding that traumatic event or traumatic stress in their body that then presents as pain as an outlet?
yeah, I suppose that's a really, really interesting discussion. Look, when it comes to particularly fibromyalgia, but also, very relevant to localized chronic pain. Um, some sort of trauma is usually involved, not in every case. I can't say that 100% of my clients with fibromyalgia have had, classic big T traumatic things going on, but many, many have, most have. Um, and yeah, what's going on there? I think one other thing I'd like to say is that let's just talk about localized chronic pain first. I like to sort of think about, localized trauma happening to a localized part of the body, like an injury. Okay. And it doesn't really have to be a severe injury always. Um, but maybe the context around that was traumatic or stressful in some way. Maybe this injury occurred and proper care wasn't administered. Maybe the injury that they weren't able to just rest and heal the injury. I'd call that trauma. Maybe it's just to the elbow, right? Maybe not to the whole person necessarily. And I'd say that might have led to this sensitization. Um, sensitization, we can sort of say hyperactivity or amplification. All of these things, all of these concepts and words work for it. But yeah, if we go back to fibromyalgia, the pain is typically whole body, and doesn't have to be entirely the whole body. It can be a large portion of the body, like a whole region. But most people, I'd say, would would describe it as whole body, with maybe a few areas of exception. Um, and yeah, just off the top of my head, the people that I can think of at the moment, they certainly experience more of the trauma that we think about when we think of the word trauma, the emotional distress, the really big emotional distress. That can be through medical trauma. That can be through, you can think of one person who had open heart surgery at a young age, and then from that went and developed fibromyalgia, for example.
Mm, mhm,
So yeah, and I mean, what's going on there? Look, I think it really boils down to um, the body, the nervous system, the whole person really experiencing an extremely unsafe situation that they had little control over. And if we think about the psychological, ways that trauma manifests, it's quite similar. It's something's happening to this person where they can't really escape or can't get out of quickly enough. Therefore, their body is just stuck in this dangerous reactivity. Yeah.
mm, mhm. Yeah, it's so fascinating. Hey, like because when you work with somebody, in general, have they been diagnosed with fibromyalgia, or is that
Mm,
something that you will go through the process to assist, like send them to their rheumatologist, or
mm.
at what stage do you generally see them?
Um, just trying to think. It does vary. Some people just I think most people have an idea, or they've got this idea that fibromyalgia, they've come across the word,
Mm,
and then how far along, how in depth they are into that process. They might just suspect that they've got fibro from googling, and that seems to match up with their experience. uh, I'd say more and more these days, people are further along that journey, because I think that there's a lot more awareness about fibromyalgia. So if they go to a doctor, most doctors these days will they will no longer say you're making it up, or go and see a clinical psychologist. Stop
mm,
being lazy, just start. They won't say that to, I hope. Most doctors aren't saying that these days. Most doctors are pretty aware of chronic pain and fibromyalgia, and it needs to be taken seriously, and they'll be sent off to a rheumatologist or a pain specialist, something like that. So yeah, it does vary, but most people are a bit more aware these days, I find.
yeah, I find the same. And it's almost like that when you said that whole pendulum thing happened with the chronic pain, and with with the pain just being in your brain and all that sort of stuff. And we just went, okay, the body no longer exists. Now pain is
Yeah.
just out
Yeah.
there, let's just deal with that. I feel like the same happened with fibro, and now it's starting to be, okay, maybe this is something that we need to look into, and it's being
Yeah.
not so gaslit, so to speak.
Yeah. Yeah. Exactly. So yeah, it's come a long way, which is
Mm.
great. Yeah.
Mm. And of the people, like when you work with people, what type of stuff are you doing? Like, are you using your myotherapy with them still? Or what does it look like when you're working with people?
Yeah, not so much anymore. So I'm at the moment I'm working exclusively online. So I work with people much like this format, so via video telehealth, and yeah, a lot of people that's they can't quite make the connection. They're like, hang on, you're okay. You've done myotherapy, not really practicing that anymore, but using your knowledge and your exercise physiologist, and you're working with chronic pain, but you're not seeing anyone face to face. Like, yeah, this is something I've tried to spell out on my website. I'm getting less of these queries. So it must be clear. Um, yeah, what am I doing? So I will always start off with a very, very, very thorough initial assessment. That's an extended session, where I'm just holding ideas loosely and gently, without trying to assume too much. But it typically becomes pretty clear that what someone's going through, just based on where their pain's presenting, or their history of it, how long it's been around, where it started, etc. And during that process, I'm trying to sort of find reasons to not label it fibromyalgia, just trying to keep it open that it could be something that we don't want to miss, of course.
Mm,
Um, and if they've been to doctors and specialists, then I'm a bit more confident that we're dealing with, we're pretty confident with fibromyalgia, and nothing more sinister. Um, but I suppose, yeah, once we get into it, my first goal is to, it's not always my first goal, but we want to try to get people's flare ups under control. So most people with fibromyalgia will say that, yeah, I'm constantly in pain. Like, that's always there. Some part of my body is screaming for attention, but then they'll have these really, but they'll be fairly functional with that. They'll be able to tolerate it, but then they'll experience flare ups. And that means their pain is like their body's on fire, that sort of stuff, and uncontrollable. And it's really, yeah, I think the first step is to get those under control. And that's quite possible. Um, I'll be using, it really depends on where people are at in terms of their journey, where they're at in terms of coming to me. what they're. I'm really trying to gauge their understanding of their own condition, what they understand about pain, why it's there, why they've got it. Because I think understanding it, um, understanding that there's not inherently anything damaged or wrong with your body. There's people who sort of may be fixated on some sort of disease process in their body, may be really frustrated that scans and blood tests aren't showing up results. What's wrong with my body? Why am I so special? Like these fancy machines aren't showing what I've got, and that's really distressing for people. So yeah, I'm wanting to make sure that my clients understand that this happens. This is actually something that the body can do. And I think using analogies like perhaps PTSD or anxiety can be good, because people can connect with this idea that you can have an anxiety or a panic attack about something really benign, about something that doesn't really truly threaten you, you know? And that's often how pain works. You've got this pain, but there's nothing really threatening. It's not really giving you any useful information. Yeah. And just that knowledge alone can actually make people feel a lot more at ease and a lot less stressed about what's going on. So that's usually a first step. Understanding their triggers about what does flare their pain up, because then we've got insight about, okay, now we've got a bit more awareness about things that may not be super obvious, but that gives them a lot more control. It's like, okay, every time I encounter this person, next day I've got pain. Well, what about it? What about that person is flaring you up? So we can sort of learn to get our bearings about what in our environment, in our lives, is actually causing the problems.
Mm.
Pacing is a big thing as well. Learning what their body's capacity is, and kind of learning to understand that their body, through this pain, is actually trying to communicate to them. It's like an entity of itself, and it is trying to get this person's attention. And that's a bit of a reframe, I think, as well, to form a different relationship with the body, a bit more understanding, compassion, and respect there as well. So that's that's sort of the starting phase. And notice that again, as an EP, I haven't mentioned exercise yet. So it's one of
Mm.
those things where exercise is a tool, but it's not usually the central core focus for me anyway. Yeah.
Mm. Yeah, so it sounds like you almost talk people through. What do you ever talk about, like, about the brain being stuck in protection mode and stuff like that? Is that part of
Yeah.
what you do?
Yeah. Again, yeah, it's a nice, pretty accurate analogy, but
Mm.
like pain is ultimately about protection. Like that's its purpose. It's to tell us about danger, and whether that danger is credible or not is the next thing to sort of talk about, really. So yeah, the brain can absolutely get it wrong. It does, most of the time if we're talking about chronic pain, the brain's not as accurate with pain anymore. Yeah.
Mm. And when people do share with you what their triggers are,
Mm.
are there commonalities that you hear? Like, as in, it are there movement triggers? Are there, is it seeing a certain person? Like, is there common threads?
Yeah, so I break them down, and the main ones I sort of categorize are. I always start with physical, because that seems to be the most obvious for most people. They can. It's very easy to connect pain with physical movement. Especially with more regional pain. But yes, same with fibromyalgia. So starting there is always good. And most people will say, yeah, if I do too much of a certain type of physical activity, that can trigger. But then there might be cognitive. I suppose this is it's easier to talk about this in terms of with chronic fatigue syndrome, I guess. But this is where there's a lot of similarities with fibromyalgia. Cognitive effort, like just what we're doing right now, could be a trigger. Where we are in front of a computer, we're really heavily relying on our brains here to have this conversation and talk to somebody. And this is where I suppose a lot of people can feel that their flare-ups are really random and they have no rhyme or reason and they just happen because they're just not connecting the dots between, they're maybe sedentary all day, working an office job or doing something like that, constantly just using their brains. And it's, it can be enough to put the body into, it can be enough to sort of send threat signals to the brain, especially once they're getting towards the end of the day really tired and things to do after work as well. So yeah, we're cognitive, emotional, so just emotional distress. So this can be things that might be stressful or uncomfortable to think about. Social situations, so certain types of people or just large crowds, just that's a bit more of a overstimulation type of thing. Environmental factors is a little bit more um, overstimulation as well. So environmental things could be how comfortable you are in a space. Now this might be to do with the really bright lighting, really harsh bright lighting or uncomfortable temperatures. So yeah, I think I've covered all of them. There's probably some that I'm missing, but that covers most of it. Yeah. And it's really worth going through that practice with people because it's so eye-opening and people just going, yeah, actually, now I'm seeing a pattern. I'm really seeing that, these factors or these particular types of conversations or, every time I go to this particular place, my pain might start or it might be the next day. Yeah. So that's a really powerful one.
And I imagine like even I mean, I know that you work, telehealth like this, but for people who are working, say, in a Pilates studio or, in any movement therapy, having those conversations could then lend you to being able to create an environment that doesn't have those stresses because it can be something like bright lights or when the studio is super busy or the music that's being played in the background or the types of conversations that are going on. It's all of those factors that we might not recognize ourselves because we're not suffering.
Mm.
That when we have that insight into the experience that person is happening, we can actually play such a huge role on changing that experience for the person when they come into the studio.
Yeah, absolutely. Not these things aren't always within our control, but even just bringing this stuff to our awareness
Mm,
and even just acknowledging it to the person, just to go, hey, I know that this is probably a bit of an issue for you. This is bothering you. That makes them still feel seen and heard and not so silly when they
mm,
have to say, well, I have to wear, you know, noise canceling earphones here. It just it helps normalize it. It's very, in the realm of kind of trauma informed practice as well, just being kind to and compassionate with people and their past experiences and what they need. Yeah,
mm. Will you please put on your exercise phys hat for a little bit?
sure.
And could we talk a little bit about the exercise trap? Like, could we
Yeah,
talk a little bit about why people with fibro might flare up after well-meaning exercise
yeah,
advice and stuff like that?
yeah, yeah, absolutely. So I think this probably goes for all chronic pain, and we can throw in, yeah, if your audience is getting people with chronic fatigue syndrome as well, this also applies. The nervous system, and therefore the pain response system, is super sensitive. So it doesn't take much a lot of the time for pain to be triggered. What might feel or be perceived as very, very light exercise, that person's brain might perceive as heavily threatening. Okay. I'll give you a fresh example in my mind because I saw this client today. Doesn't have fibromyalgia, but this applies. So they have chronic neck pain, and they were talking about some of their past experiences with physios, very well-meaning. And, I know one of the physios that they saw, and I know that this person is just very good at what they do. And they prescribed a very, very sensible exercise of like 1 or 2 kilo dumbbell, lateral arm raises or shoulder raises. Okay. And this client said that after doing that exercise, I think they did, 3 reps of 10. So nothing too scary and really, really lightweight. They had like 3 or 4 days of really severe pain, like in their neck after that, really severe headaches for, half a week or so. And if you sort of think about that, that makes no sense because we're talking about 1 kilo, and this is a 30-something, otherwise pretty fit, pretty healthy person. Okay. Nothing wrong with their muscular physique at all. That makes no sense. That is not a threat. That is not damaging. It's not dangerous. It shouldn't be a problem. They were only lifting to like 90 degrees, no overhead. So the physio was quite careful, but even still, even that small amount of exercise, and the client said it's the repetitive nature of it. It's like when there's just too many reps of anything, that's going to trigger her pain. So that's what her pain system is sensitive to. So often we have to scale things back, way back, to well below what we think somebody can do. And I'm actually going to sort of, I suppose, refer or reference a previous guest of yours, Jeannie DeBon. I believe she's been on your podcast. I think I saw her. Yeah.
Yeah, last year.
I've just recently done her course, on exercise for hypermobility. And something that really resonated with me with that was she talks about doing amount of exercise that should feel really boring to people, as a starting point. So she will say unloaded exercises. The focus is not about getting stronger at this point. We'll go with that, stronger. It's more about creating some familiarity with movement and some safety, some contextual safety with these movement. Let's actually get this person moving and not flare them up. That's success, really. If we can get them moving, they're going to have a positive experience with that. So we can just maybe add on a little bit more next time. But if we can try to start from a place that we're really, really confident that is not going to flare them up, then they can come back next time and then they can do a bit more. If you start them from a place of doing too much, then we have no idea which number, which rep, which amount of weight was the threshold point, I guess. Yeah. Does that make sense?
Oh, totally. Hey, it can be such a frustrating experience from what I see for people who live with a chronic condition like this, and they come into whether it's a physio studio, a Pilates studio, exercise, whatever, and they wanna be able to do things, but it's so
Yeah,
difficult from our perspective as the movement educator. We can't necessarily see what's when they're, when they're struggling or when something isn't working well, and if we haven't felt what somebody is going through, it's really hard to identify these things, isn't it? But yeah,
absolutely.
Jeannie talks about it really well, and obviously she has such a fantastic program that she runs. You're literally just learning how your body moves in space, and you're using your
Yeah,
own body weight
yeah,
to start to feel into those things. And I think as a educator, it's really about being able to strip back movement to the intricacies of movement,
yeah.
and allowing people to feel safe with some,
That's
just
it.
being there, full stop.
Yeah, yeah. And I mean, this is, what Jeannie does is so relevant it's so applicable to Pilates. I know
Oh,
she is a Pilates
tons.
instructor by
Mm,
background. But yeah, like this is stuff that can be bread and butter for Pilates
mhm.
instructors, which is fantastic. So it's very, very easily applied. And yeah, what you said there, it is really just about, making the whole situation as safe as possible, not just um for not just, I suppose, safe in the awareness of the person, but also to their nervous system. And I think that's where just a really, really easy hack for people who are exercise professionals. This is what I do before I it's kind of safeguards what's about to come in terms of like your exercise prescription. Just do some doesn't have to be elaborate, just some brief body relaxation exercises or practices first. You know, get the person to just sit or lie, whatever it is, close their eyes if they're comfortable with that. Do some parasympathetic breathing. Just, normal inhale, long out breath, couple of minutes of that. Get them to ground into their body. If that's again, if be very trauma informed about that. Like if that's not a
Mm.
bit of a dodgy thing for people to do, not dodgy, but if that's a bit sketchy for people, then yeah, just get them to sort of feel rested in their body, then start the exercise. So they're going to be starting from a place of safety, hopefully. Yeah. And you can also break up the session as well, like lots of breaks. Okay. Just, while I'm focusing on another client here, all I want you to do is just rest. Give yourself permission to rest. You don't have to work hard in this class or in life all the time. Have rest. That's also part of this. And then afterwards as well. And you're much more likely to have a successful flare up free session that way.
Yeah, absolutely. Yeah, we spoke if, for you guys listening, the episode that I had with Carla Mullins is a great one as far as, considering programming for people with fibromyalgia. She, definitely touches on, and I agree with her that, the reformer fad that's around at the moment, may it rest in peace at some stage, but is not necessarily the ideal situation for somebody with fibromyalgia. But either mat classes, which lend themselves for somebody with fibromyalgia, can definitely have a little bit of a break in a mat class and can maybe not do as many reps and doesn't seem to get taken away by what seems to be the race that's happening in the reformer class,
Mm,
and otherwise like a semi-private setup, where
yeah.
the educator is going from one person to another, and it allows for the person to take the breaks without feeling like they've got to keep up with everybody. So there's definitely more appropriate choices for people with fibro we see in the studio, and I definitely don't think that a reformer class is necessarily the best place for them unless that class is specifically catered to people who are living with chronic conditions. But can we also touch on, oh gosh, sometimes I babble and I just babble and now I can't think of what I was going to ask.
I can resonate
Um,
with that. Yep.
I know. Damn it. What was it? You spoke of something. You talked about Jeannie Devon. Shit, I can't think about it. Um,
Hypermobility.
Yeah.
I think
Oh, no, trauma informed. You
yeah,
touched on trauma informed. Could you explain, just in case we've got anybody listening, what
yeah,
does trauma informed mean? And I I mean, like, definitely it's worth doing training on being trauma informed. There's some fantastic courses on trauma informed yoga practice,
yeah,
not specifically in Pilates, but there's definitely some great courses on trauma informed for movement practitioners. But what does it mean to you when you're working with
yeah,
somebody?
yeah. So, to me, it means that I'm trying to be aware that somebody might have had traumatic experiences in their past. You could argue that most people have to some degree or another, and that there might be triggers that they may get triggered, their trauma may get triggered by seemingly benign things that no one outside of them will be aware of. Okay. So, um, an example about how I might do this if I was, in a physical, in the same physical space as somebody, um, I might position a room so they can see an exit, be it a window or a wall. They might just have that's a common one. I think that's just a common practice that is taught in trauma informed practice, is to just make sure that they can see an exit strategy out of there. It's not to infer that you are dangerous or your premises is dangerous or anything like that. It's really more about they might have been in a situation where they couldn't escape, and they just need to have that assurance. They may not even be aware of that, but their nervous system might be. Um, so it's things like that. That does that give you enough there, or yeah,
Yeah, yeah. And what about if I was um if I am teaching, this is the way that I think it partly about being trauma informed or teaching in a trauma aware place is
yeah,
in making sure that my approach to teaching is not dogmatic, but it always
yeah.
has an invitational,
Oh yeah,
um,
that's a good.
and there's an invitation to let's try this. And when you do that, how does that feel for you? Or let's try this. And if it feels appropriate, the next level of that would be this, rather than being like, and now you do five of this, and now you do five of this, and then you have to do. To me, it's about the language that we use and the way
Yeah.
that we invite people into that experience.
Yeah, really, really well said. Yeah, absolutely. I think that invitational language um, is super powerful, and I think it's really, really powerful. And it's easy language for us to adopt. Um, it you know they may not have ever been given a choice. So for us to say, you don't have to do this, you're in charge, you are autonomous, you are allowed to walk out right now. You know, that's totally
Mm,
fine. It's for us to normalize that and make that okay can be super. That in itself can just be really, really healing for them. So yeah, that's going to make them feel very safe. Yeah. So yeah, very well said. I'm glad you brought
mm,
that up. Yeah, 100%.
mm. And so, what about if we weave that into, I guess, the nervous system and regulation when it comes to fibromyalgia? Wh- What do you think the role of the well? Um, what do you think the autonomic nervous system like? What's happening when somebody is suffering from fibromyalgia when it comes to the nervous system?
Um, yeah, I think we could probably talk about this on lots of different levels, but what's happening fundamentally is that the nervous system is predominantly going to be in more of a fight or flight sympathetic tone. It's going to be if it's not in that phase, it's going to be very easily triggered into that phase. So fight or flight, again, it really comes down to our autonomic nervous system and our brain, especially. Its primary job is to keep us alive and to keep us safe and out of threat, basically, and it's a very primitive sort of thing that doesn't really know about social norms, what's appropriate to say and do. It's very animalistic. So and pain is one of the oldest and most primitive mechanisms that it's got, and pain is such a strong. It grabs our attention. Like, you can be in so much pain that nothing else in your awareness. There's no other form of awareness. It's really just all you can see, feel, hear is pain. So it's so powerful, and yeah, your nervous system is utilizing that protective pain system that is wonderful that it's got to tell you that something's wrong. And again, it's not super sophisticated. It can't always tell you exactly precisely what's wrong. It's just saying something's wrong. I want you to change something. I want you to get out of this situation, do something different, essentially. That's what it's trying to communicate.
Mm. And so if going back to the very beginning of the conversation, when it comes to your nociceptors and there's this scramble or this excitement of information, your nervous system is, in fight or flight, or, ultimately telling you that you're in danger, or your brain is perceiving that you're under threat. What are some really practical regulation tools that you give people so that they can help manage that?
I think the first one is expectations. Often we can't immediately get rid of pain straight away. We can learn to put it into context. So I think that's where it comes back to, or I like to come back to making sure that person is really educated about, like, okay, what is this pain? Let's not try not to over-identify with it. I mean, that can be super tricky if somebody's just, in screaming 9 or 10 out of 10 pain, right? But most of the time they're not. So yeah, just having that awareness that, okay, I'll give you some practicals. Self-talk is really, really powerful. Okay. And it does come back to this education. If you can say as a truthful, authentic safety affirmation, like, my body's sore, this part of my body's sore, but I know that I'm safe. And that can be a bit of a mantra that can help. Okay. So that's one. So that's a very, top brain down sort of process. Involves the prefrontal cortex. Parasympathetic breathing. So what that means is just a full belly breath in, but making the exhale longer, and not just one breath, not just two breaths. It's more of a practice. So let's just get into the rhythm over a couple of minutes. That can help. Anything that sort of communicates some cues of safety to the nervous system, and sometimes we have to hunt around and find them. Not all of these things are going to work every time. I encourage people to experiment, but we can go through that process. Could be changing positions, lying down if you're seated, or standing up, moving. Can be doing a bit of a shakeout if that feels okay for your body. Again, very invitational. Can be going outside and putting your feet on the grass. So that can be very grounding and soothing. It can be talking to somebody. It can be, it's really about, I think, fundamentally figuring out your body's language. You can, and some people are good at this and some people are not so good at this, but it's a skill that can be learned. It's just trying to interpret, like, what do I need or what does my body need in this moment? Sometimes it is a big deep breath. Sometimes it's to roll your shoulders. Sometimes it's to get away from the screen or get away from a situation or have something to eat, have something to drink. Sometimes just the basic comforters can help. So that's sort of quick and, I mean, I was going to say easy, but it can be probably quick and simple things is probably a better way to put those sort of things. Often there's a mindfulness technique called somatic tracking, and this comes from the work of, I forget the guy's name, but it comes from pain reprocessing therapy. And this one I find to be highly effective to some degree or another. It's essentially, like I said, a mindfulness practice, a guided mindfulness practice, which I will do, but there's also recordings online of these, where it's to visualize your pain and try to sort of mentally approach that part of your body, but in the context of safety. So we do a lot of, relaxation first, a bit of like a body scan. And this will also definitely come after this person understands that their body is actually ultimately safe, and this pain is a bit misrepresenting. But yeah, when we're sort of approaching pain rather than fleeing from it or pushing it away or, you know, having that element of fear around it, that can be quite empowering as well. It can really help change the relationship between the person, the brain, the pain, that part of the body, all of that sort of stuff. So yeah, that's a bit more of a fancy one, but highly effective.
So is that
Mm.
somatic tracking? It's almost like you bring awareness to that area of pain. Is it literally just that? Like you bring awareness to it, be aware of it, notice it, and
Yeah.
then be okay with it, or are you trying to change it?
Yeah. So that's a really important thing. We're not inherently trying to change it at that point. It's more about we're coming at it from a place of um, knowing that our body is okay and accepting and just allowing that pain to be there. We're trying to just be a bit more of an observer of it in that case. And, we can get a bit more fancy and start doing that while people are moving. Just go,
Mm,
when you do this, let's just notice and allow that pain to be there. And again, there's the safety concern there is we just want to make sure that the pain doesn't get extreme. Like we're not trying to chase a flare up here. But if it's a gentle ramp up, let's just see if we can tolerate that, but give people the autonomy. Again, it's very invitational to just abort and go, okay, that's enough. And again, that can be really empowering as well.
mhm. Yeah, and I guess it's that weaves back to that whole, giving your brain different information to what your brain
Yeah.
is processing, right?
Yeah, correct. It's giving I mean, the brain absolutely loves fresh, new, novel information.
Mm,
So, and and pain thrives in an environment of habit, I guess. Some people
the
have called
same,
pain
yeah.
a habit,
Mhm,
actually.
mm,
And at a, at a neural level, pain actually is, it's a circuitry of habit that just keeps getting run over and over and over again. Every time I bend over, when your brain registers that movement, pain just automatically happens out of habit. So if we can
mm,
introduce some different elements there, um, yeah, and I think, something that's quite specific and relevant to Pilates and movement instructors, if somebody, as a good example, if somebody is getting pain when they bend over, their back starts to hurt. Well, what if we put them in supine and get them to do a similar bendy ovary sort of movement, but now they're on their back? But essentially the movement is still spinal flexion. Sometimes
mhm,
pain can just not be there,
mm,
and I always love trying to find the exception to the rule, in somebody's pain story. every time I bend
Mm.
over. Okay, so what you're saying is when you flex your spine, pain starts. Okay, well, let's try flexing your spine when you're upside down, or whatever. Yeah. So that's a really interesting thing because often pain won't actually be there.
Yeah, that's so cool. So it's you like, okay, so let's reframe the story. Let's change that story. Yeah, by changing you, I think of it as your relationship with gravity, but basically changing your body position. Do
Yeah.
you know anything about once I listen, I love Huberman
Yeah.
podcast, and I was listening to a podcast that I forget what it was about, but he definitely touched on addiction, and he talked about the neural pathway of addiction is like this very deep neural pathway, which is why it's so easy for people to fall back into that. He talked about it. It's almost if you imagine two streams of water, and there's a very shallow stream of water, which is the pathway of not being addicted, but then the pathway of addiction is this very deep crevice, and so it's very easy for the nervous system to fall back into that because it's such a deep crevice. Is it similar with pain? Do you know?
Um, Not for sure, but like I would say that's probably a similar story.
Yeah, that's
Yeah,
what I wonder.
like
'Cause it's almost like that
neurologically.
that habit
Yeah.
forming, you know?
Yeah, yeah, that's right. I mean, the analogy that I've heard with this sort of stuff is uh now I've got to get the story right. It's we've got a mountain with snow on it, and when you at the start of the day, people are skiing down or snowboarding down mountains, and the more people go down those same runs, the more entrenched they get, and the quicker they get, and people can't really deviate so easily by the end of the day off those runs anymore. So that's like your habit, but then overnight you get a nice fresh powder of snow, and those habits aren't really there anymore. So that's kind of analogous to, well, if we can stop using that run and try some different
Mm,
runs,
mhm,
we can form new ski runs, or in this case, habits. Yeah.
mm. Yeah, that's how I imagine the pain receptors because, when we work with people, for a while, they'll be like, "Oh, no, I'm good. I'm not I'm not in pain anymore." But then something will happen, and then they're back there again, you know?
Yeah.
So I wonder if it's that similar kind
Yeah.
of concept. Yeah, I don't know enough about it, but that's just how I
I
imagine
can
it.
an interesting. Okay, so here's a really niche and interesting corner of pain research at the moment.
Mm,
Um, and I'm sort of close to this because I've got some friends who are psychotherapists and work in this very niche field of psychedelics. Um, there are some studies right now that are looking at classic psychedelics. So we're talking like psilocybin, which is the active ingredient in magic mushrooms.
mhm,
LSD is another classic psychedelic, and there's a few other ones. And they can use these therapeutically. And they've discovered a long time ago that these things are highly effective for lots of mental health conditions like, um, treatment resistant depression and anxiety, PTSD, lots of different things.
mm,
What these compounds tend to do to the brain is open up this window of new learning opportunity. Like high levels of brain plasticity are ripe in this moment, and they're all a little bit different in terms of time frame. I think psilocybin gives you about a week's worth of really high levels of brain plasticity. And um yeah, someone that I know is, I think they're either just started or very close to starting, maybe a couple of months away, but looking specifically at um, treating fibromyalgia with psychedelic assisted therapy. Yeah,
mhm,
here in Melbourne as well. I think they're at Monash.
mm.
Yeah.
Oh,
So
fascinating.
yeah, and it's based on this idea that okay, like when somebody is in this state, um, you know, new neural connections can be formed. We can break out of this habit of pain. I mean, that's the basis of it. So yeah,
Mm.
that'll be a really fascinating thing. I don't think it's the first of its kind. I think that there's been some studies similar in other parts of the world already. So there's already pre-existing data on this that looks like it's been pretty successful. So
Mhm.
yeah, that'll be. I'm super fascinated about that.
Yeah, absolutely. I mean, if for people who live with a chronic condition like for so long, you'd have to be open to,
Yeah,
to giving many things a go. Hey,
absolutely. Yeah, and especially they've just had so few answers in this space for so long, and everyone's just still the medical world is saying, well, you can't get rid of it. It's something that is you're just going to have to manage. So
Mm,
and I think we kind of started this in this space about can you get rid of it or are you stuck with it forever? And I would say that look, I don't think the word cure is appropriate here. I don't think. Oh, I must have gestured. It's just given me a little okay sign on the screen. Um, I don't think cure is appropriate. I think cure is reserved for when you've got a biomedical disease and there's a medication or there's surgery or something like that
mm,
that can cure something. Okay, I don't think that's appropriate to use here, but you can absolutely get better from fibromyalgia. You can absolutely maybe remission is a good word. I'm not quite sure. I'm not 100% certain which word to use here, but you can certainly recover. You can certainly get to a place where you can function a lot better. Certainly get to a place where um, you where it's just not really having a significant impact on your life anymore. That's all 100% possible. I've seen it, and many of my colleagues and people that I work with have worked with in the past have seen it. So yeah, you can get to that place where you're pretty okay. So that's
mm.
promising.
Yeah, and that's what I've gotten from the few other people that I've spoken to who are either living with it or have lived with it. Is I think one girl did use the word remission.
Yeah.
Another girl said she feels like she's overcome the
Mm,
condition. But
mm.
if she still does everything to manage it, right? It's so that it doesn't
Yes.
take over her life. So there's still a lot of mindful living for her to be
Yeah.
able to do that. It's not like she just walk
Yeah.
away from it.
And I think, this is where, no one's ever going to choose to put their hand up and say, I want to have fibromyalgia when I grow up. No one wants that. But, the lessons that can be learned from dealing with a hardship like this can be, learning what your body needs and what sort of how to care for yourself, how to give yourself more space, more time, say no to things that you previously would have said, a coercive yes to. Um, those sorts of things, like prioritizing yourself, can come from this. And yeah, I think like most people with fibromyalgia probably still have a bit of a sensitive nervous system. Like they can still get triggered if they're a bit reckless, if they let their, if they're not prioritizing their sleep or other aspects of their health, mental health, physical health. Yeah, it's probably your brain's going to not necessarily lose those circuits or pathways or the ski slopes, um, but they'll become a lot more dormant and a lot more quiet. But they can certainly be reactivated. But it becomes a lot more manageable at that stage. You'll see it coming a mile away. You'll go, okay, right, flare up. We can, and you'll have the tools. You'll have the
Mm,
tools and know what to do from there.
mhm. Yeah, I think that's a really, really important message for people. So I guess this is probably a really great place to wrap up this conversation because I feel like we've gone on a few different um, pathways. So what message would you want to leave with people who are working with who are working with people with fibromyalgia? What do you think is something that people need to hear?
Yeah, that I think first and foremost that if you're starting to see people with fibromyalgia, these are probably people who have not had a good run with medical and healthcare systems and people working in those systems, unfortunately. So, um, believing what they say and understanding them and listening to them when they say that, certain things trigger them or they've had enough of an exercise. That, and also, because we're dealing, your audience is predominantly movement professionals. The aims of exercise of any sort, not necessarily about getting fitter or stronger. It's more about, like, there's therapy just in moving and just being in your class, um, just that, and being there and being able to move their body. They're going to feel good if they don't flare up, basically. So often
Mm,
less is more.
mm. Yeah,
Yeah, I think that's
key
probably
to that.
a good message.
Yeah, I think that's amazing. Thank you so much for your time, Rob. I really
Mm,
appreciate your
it's been
sharing
really
all of
fun.
your insight. Yeah, it's awesome. So guys, you know that you will find Rob's details in the show notes. So definitely go check him out. I've had a look at his website. It looks fantastic. And there's more to come, no doubt. But
Yep.
just while we're
There is.
here, would you like to share the best way for people to find you? Like, are you on socials or do you prefer the website? Where's the best way to find you?
Yeah, I definitely prefer the website. I have relationship issues with Meta, so I'm
Good.
on there, but I'm just, yeah, it's not something. Look, to be honest, I don't have time to do socials, and I don't like socials. So yeah, website's best. Yeah, that
Mhm.
would be great. Yep, and that'll just be in the show notes, will it?
Yeah, absolutely. Yeah. Yeah.
Perfect.
It's all in the show notes. If you want to share it, you're welcome to, because a lot of people don't read show notes. So you want to just share your website while you're here?
Yeah, fair enough. So the business is called Heal and Thrive. Website is just healthrive.com.au. Yeah, so there's no and in there. It's all one word.
Awesome.
Heal.
Perfect. But yeah, check it out, guys. Definitely check it out. The more we can share information and keep learning from each other, then obviously the more that we can share and serve our community, which is what this podcast is all about. My name's Katie Crane. Thanks so much for joining me. See you next time on the Pilates Lounge podcast. Amazing.